things. Yes, I was going to ask about the recording and just make sure that we have all of our speakers. Let me do a quick scan. Hello. Okay, welcome our friends. Okay, so I'm going to go ahead and start. Good evening, everyone. I see we have people still connecting. Welcome, welcome, welcome to our second event of the week. This is a busy week for Mother Lab. We are pumping. Last night we had our fall open house, and if you want to learn more about that, you can follow us on social media or check out our website. Tonight is a really exciting event. We're going to be talking about Black doula work in Western Massachusetts, and it's going to be a conversation and also a research presentation. So for those of you who don't know who I am, good evening, welcome. My name is Dr. Mutanakaga. I'm the founder and PI of the Mother Lab, and we're so excited to have you tonight joining us. Mother Lab is about a year old. We were founded in July 2020 at the height of the pandemic, and Mother Lab stands for Maternal Outcomes for Translational Health Equity Research. That's what Mother is the acronym for. And it's my job to steward this amazing group of 35 brilliant scholars who are focused on addressing maternal health disparities from undergrad, master's, PhD, MD, MSW, nursing, and everything in between. And we're so excited for you all to join us. Please feel free to interact in the chat. If you guys could go in and say where you're zooming in from, and what brought you to this event tonight. Are you a doula yourself? Have you had a positive experience with doula? Do you want to learn more about what doulas are and the work that doulas entail? Are you from Western Mass? You can give a shout out to your hometown in Western Mass, or maybe that's where you're living or working. But just let's start a little bit of a conversation in the chat. And without further ado, I think I'm right at my time, 6:05. I'm going to turn it over to my amazing Research and Grants Committee to start us off. Thank you all so much.
Hi, Dr. Ayo, and hi, everyone. Welcome to this presentation. My name is Anna, and I'm one of the co-chairs of the Research and Grants Committee here at Mother Lab. Sorry, I got distracted by one of the admitting people things. We're so excited to have two of our undergrad students present some of their research on different disparities that are going on in the United States, but specifically in Western Massachusetts. So from here, I'm going to pass it to Subecha and Marwa.
Hello, everyone. My name is Subecha.
Hi, everyone. My name is Marwa.
And like Anna said, we are both members of Mother Lab's Research and Grants Committee. We would like to welcome you all to our Black doula work in Western Massachusetts, a conversation and research presentation.
So just to start off, we're going to go through the agenda. So throughout the presentation, we're going to touch on a few very connected concepts. So just some maternal health disparities in the US in general. And then we're going to go into maternal health disparities specific in Massachusetts. And then we're going to talk about Western Mass maternal health disparities and the need for more research in Western Mass specifically.
According to the CDC, between 1987 and 2017, the US was the only high-income country in which maternal mortality increased. It more than doubled from 7 deaths per 100,000 live births in 1987 to 17 deaths in 2017. Most maternal deaths are preventable, but maternal deaths have been increasing in the US as of recent years. In 2018, there was 17 maternal deaths for every 100,000 live births, double the ratio of other high-income comparable countries. As you can see in the figure, our North American neighbor Canada has the closest ratio at 8.6 per 100,000 live births, which is still significantly lower.
So going into some statistics about the US maternal health disparities, we see that for every 1 maternal death, 100 women experience severe maternal morbidity, which is including but not limited to blood transfusion, acute renal failure, shock, acute myocardial infarction, respiratory distress syndrome, aneurysms, and cardiac surgery during delivery hospitalizations. Within this, we see that non-Hispanic Black women are more than 2 times as likely as non-Hispanic white women to experience severe maternal morbidity. According to a study looking at the consequences of increasing severe maternal morbidity, or SMM, we see that the consequences are very grave. It includes a higher utilization of health services, higher direct medical costs, extended length of hospitalization, and a need for long-term rehabilitation. In order to understand disease patterns of pregnant and postpartum women and to create appropriate interventions to improve maternal health and care, we need to look into studying maternal morbidity as well as maternal mortality.
What causes these disparities? At the core of these disparities is structural racism. Structural racism has shaped the environment to disadvantage Black women through housing practices and redlining. Black women also are more likely to lack access to healthcare and insurance coverage. Implicit bias also plays a significant role in medical settings, with medical providers being less likely to accurately gauge the pain tolerance of Black women. Additionally, Black women may be less likely to seek out medical treatment earlier in pregnancy, in part due to concern of encountering racial bias in medical settings, even if individuals do have access to healthcare. Black women are also more likely than their white counterparts to live in maternity care deserts.
So this slide's kind of going more into details about the past slide. And so we're looking at systems of oppression, and systems of oppression have an effect on multiple and all socioecological layers. And so previous studies have shown that Black women are more likely than white women to undergo substandard medical care, which is definitely a factor of institutional issues in hospitals and policies, and as well as implicit bias within the system, and for providers that have implicit bias who show it implicitly and explicitly. Black women are also more likely to have unnecessary surgeries like hysterectomies. They have an increased risk of HIV, which is associated with the history of mass incarceration for Black men. So that goes into a broader structural discussion in which we need to have a conversation about dismantling and changing systems of mass incarceration, and those have an effect on Black women and their maternal health as well. And like I've said before, when you look directly at the healthcare system, there's a consistent proof of implicit and explicit racial bias that affects Black women and results in disparities. When we looked at a study examining county-level racial prejudice, we found that the Black-white gap in low birth weight is 14% larger in counties with high implicit racial prejudice compared to counties with low prejudice. And the gap between Black women and white women in preterm birth is 29% larger in high prejudice counties. On a more systemic level, like Shubhatra said, we see that a lot of the disparities are caused by geographical reasons, mainly maternity care deserts. And, I think it's a past slide. Thanks. And so when we look at maternity care deserts all across the US, we see that 5 million women in over 1,000 counties across the United States are in a maternity care desert. So according to the March of Dimes, maternity care deserts are counties in which access to maternity health care services is limited or absent, either through lack of services or barriers to a woman's ability to access that care. So the following figures are taken from a study that show that between 2004 and 2014, 9% of rural counties experienced the loss of obstetric services. 45% of rural US counties have hospitals without OB services, and rural counties with fewer OBs and physicians have a higher percentage of non-Hispanic Black women and lower median household incomes. Additionally, we see that for reproductive aged women in maternity care deserts, there's often no health insurance coverage, no usual source of care, and no routine checkups.
When comparing rural versus urban health, we can see that rural severe maternal morbidity probabilities are worse than urban severe maternal morbidity probabilities, but the probabilities have steadily increased within the years, as we see in the figure. Non-Hispanic Black, American Indian, Alaska Native, Hispanic, and Asian residents of both rural and urban areas had at least 33% increased odds of severe maternal morbidity and mortality compared to non-Hispanic white residents. Severe maternal morbidity rates in rural and urban US residents, regardless of race, in this 2019 study projected a rising percentage of severe maternal morbidity probabilities. And this is even before COVID-19 has even been represented, and its associated trends have been studied in literature. Next slide, please. Non-Hispanic Black women have more than double the rates of severe maternal morbidity compared with non-Hispanic white women in Massachusetts. Severe maternal morbidity rates were highest among non-Hispanic Black women at 89 delivery hospitalizations per 10,000 compared to white women who had 37.8 per 10,000. As shown in the figure from the study conducted in 2019, looking at the years 1998 to 2013, the severe maternal morbidity rate in Massachusetts nearly doubled and has only continued to increase since then.
So when we look at Massachusetts specifically, in a Massachusetts Health Review by the Mass State Department in 2017, it was found that factors that coincide with severe maternal morbidity are depression and prenatal care. So postpartum depression, as we know, is a very serious and debilitating disease that impacts both maternal and infant health. And we see that racial and ethnic disparities in the prevalence of postpartum depressive symptoms exist. As we see in the figure, mothers who are non-Hispanic Black women, so 20%, Asian 16%, or Hispanic 15%, had a higher prevalence of postpartum depressive symptomatology than non-Hispanic white mothers in Massachusetts in 2014, which is the year that the 2017 review was examined.
Prenatal care is one of the most frequently used preventative health care services in the US. It is important for preventing maternal mortality and morbidity, as well as infant mortality, by allowing for the detection and management of potential birthing complications. Prenatal care also provides a setting for health education and behavioral interventions. Persistent disparities remain in the percentage of mothers receiving adequate prenatal care by race and ethnicity in Massachusetts. While the percentage declined during the 2012 to 2015 period, as we can see in the figure, in all racial and ethnic groups, the largest decline of adequacy of prenatal care occurred among Black non-Hispanic mothers.
So in the recent years, we've seen that Massachusetts has tried to make some sort of improvements, but unfortunately they haven't been enough. So when we look at reforms that were made to the Massachusetts Affordable Care Act to increase access and decrease inequities, there was no significant change in the inequities that exist, which we can see in the graph. Like, there's not really any sort of change and improvement in health that's been significant. So barriers to that lack of change have been, or like to making that change, have been the fact that cost is a very big issue. There are a lot of underinsured folks, language barriers. There are people who are insured, but they don't have a PCP or primary care physician. And private insurance is also more commonly accepted. And so often people who might be insured through Medicare or Medicaid can't go to specific, or have a difficult time getting access to specific hospitals or clinics. There are also still issues on a more interpersonal level. A study looking at racial and ethnic disparities among opioid-exposed mother and infant dyads between 2004 and 2019 found that non-Hispanic Black women and Hispanic women were less likely to receive medication for opioid use during pregnancy. So this shows that inequities exist on all levels. And reforms to specific insurance policies might be one step in the right direction, but there's clearly more work that needs to be done in Massachusetts. And I'm sure that there's a lot of literature that shows that that can also be translated onto a broader level in the US as well.
It is important that we frame these healthcare and healthcare access disparities we see in the US and in Massachusetts in relation to other comparable high-income developed countries. What are they doing that we're not? Compared to other developed countries, the US has a shortage of maternity care providers, especially midwives, and we lack comprehensive postpartum support. Obstetrician gynecologists, also known as OBGYNs, are overrepresented in the US maternity care workforce relative to midwives, but overall, there is a shortage of all maternity care providers, referring to both OBGYNs and midwives in the United States. In other developed countries, midwives outnumber OBGYNs by several fold, and primary care plays a central role in their health systems. We can see this in the figure in the slide, because in comparison to the European countries represented in Australia, we fall substantially behind the number of maternity care providers we possess. And so how can we fix that? Next slide, please. How can we fix this problem? Midwives, doulas, and birth-oriented community healthcare workers are trained healthcare professionals who support and care for women during pregnancy, labor, and birth. Doulas, midwives, and other community care workers who offer emotional and social support can serve as meaningful liaisons between the physician and mother, limiting these maternal healthcare disparities, especially for Black women. In the limited research that has been conducted with this work, findings for severe maternal morbidity improvement for mothers are promising. Doula-assisted mothers were 4 times less likely to have a low birth weight baby, 2 times less likely to experience a birth complication involving themselves or their baby, and significantly more likely to initiate breastfeeding. Communication with and encouragement from a doula throughout a mother's pregnancy have increased a mother's self-efficacy regarding her ability to impact her own pregnancy outcomes. Additional health benefits have included a decreased use of pain relief medication during labor, decreased incidence of C-sections, decrease in the length of labor, and a decrease in negative childbirth experience. The Center for American Progress reported on a recent case study from one nonprofit organization in the DC area, whose mission is to support mothers of color, that when low-income and minority women were provided family-centered care from a midwife, doula, and lactation specialist, they had 0 infant and maternal deaths, and 89% were able to initiate breastfeeding. Making doula, midwifery, and community healthcare workers readily available will help improve Black maternal health in pregnancy, delivery, and postpartum care, and improve severe maternal morbidity and mortality outcomes in the US and in Massachusetts.
So we want to highlight that this event was meant to recognize and highlight Black doula work in Western Massachusetts. But when we look at affiliated research and literature, we see that there really is not a lot of information on doula work in Western Mass, or really disparities in Western Massachusetts in terms of maternal health care. So Subecha did a very in-depth search for this towards the end, while we looked through our literature and we said, there's nothing about Western Mass here. What do we do? And the search terms that we used were Western MA or Western Mass or Western Massachusetts, and maternal health or severe maternal morbidity or maternal mortality, which created 4 pregnancy and maternal health related search results. And all studies that, like, the population that they looked at were Latina women. 3 out of the 4 studies utilized Proyecto Buena Salud, PBS, from Bay State Medical Center, and 1 out of the 4 used Bay State Medical Center ambulatory obstetrical practice data. And so there wasn't really any research specifically on Black women. There isn't a lot of data looking at Western Mass and disparities as a whole. A lot of these, as you can see on the slide, we're using past data sets to focus on Latina women, and we're very specific and focused on interventions, which are very, very important, but it's also important to recognize that that disparity, like recognition of these disparities and work towards these disparities for Black women specifically has not been researched. And yeah, so that's a clear problem. And next slide, please. So we thought that it would best to end our discussion talking about the next steps in research, focusing on Western Mass and in many rural counties all across the US. There needs to be a focus on equity in research, which means that we need to explore disparities through the socioecological model, which means that we need to look at, systems of oppression and how they affect women of color, specifically Black women in maternal health on all levels of society, which means institutional, interpersonal, systemic, because systems of oppression act to create inequities in all those levels and through all those levels. We need to have translational research, which means applying that research to interventions and doing active work. And an application of nationwide research on smaller scales. So we see that there's clearly data on maternal health morbidity and maternal health disparities over in like the whole entire US broadly, but there isn't really a lot of research looking at smaller scales where it might be easier to implement more interventions and start small and then go big. And so we think that in tandem with the work, the nationwide research that we're doing and the nationwide interventions that are being done, which are equally important, there needs to be also research done at the same time on smaller scales in places like Western Mass.
So that was our presentation, and since we are in the Mother Lab, we would love for you to please contact us with any questions. If you just have any questions about Mother Lab in general or questions regarding maternal health, you can look more on the work we do at our lab with our website, motherlab.org. You can also email our two co-chairs for the Research and Grants Committee, Anna Kiefitz and Dr. Carrie Carvalho, with the emails provided on the slide. You can also email our marketing email if you have any like non-research related questions, specifically about the Mother Lab, how we work, like what we're up to, or you can contact us on social media. The two platforms that we mainly use are Twitter and Instagram, and the usernames for Twitter is @MotherLab20, and the Instagram username is @MotherLab, mother_lab. So feel free to reach out. We're always checking, we're always checking our stuff. So we'd love to hear from you outside of this meeting as well. And I think there's one more slide that just says thank you.
Thank you so much, Subecha and Marwa. That was a great presentation. That was very thorough and sets us up for this next portion of our event today, which is a discussion portion that is with our amazing doulas here today, who are our guests for this event. And hopefully, if we have time at the end, we can also have a small Q&A session. So to set us up, I'd love to briefly introduce our guests here today. So thank you all for being here, and thank you for our guests for making time to be here today. First, we have Tanita Council, who has been a birth and postpartum doula since 2019, and also works as a lactation counselor, who has special interests in working on breastfeeding support and with LGBTQ families. And on her online profile, it says, "I'm traveling from Springfield, MA, and don't mind traveling up to 90 minutes each direction," which I think says something about Tanita's dedication and passion for this work. And our other guest is Dashanna Hanlon, who is a birth and postpartum doula and founder of Caring for Mamas, which focuses on childbirth education and support. Dashanna was moved to action by the conditions that pregnant and birthing people and their families endured during the COVID-19 pandemic, and was inspired to take action through Caring for Mamas. So thank you for being here today. And I have a few guiding questions that Iman and I will actually be asking throughout this session, but feel free to touch on any relevant points or experiences that you'd like to bring up. So the first question that I will pose to both of you is, in your experiences, what are some challenges that have existed in doula work in Western Massachusetts, both before the start of the COVID-19 pandemic and now in the midst of it?
I guess I'll go first, Tanita. Up to you. So a lot of the, I think, issue with doula work in Western Massachusetts is getting people to know that there are doulas, getting them to, sign up for doula support, understand the value in doula support. When people look at, the cost, it can be like a big deterrent. So a lot of us, offer scholarships, we apply for scholarships, all that kind of stuff to get the word out. But I would say that's probably one of the first things that's a little difficult about doula work in Western Mass.
I would definitely agree. I would say that, and as well as honestly the getting paid part. I mean, obviously you want to help everybody, and you want everybody to be helped. But when it comes first, it's the effort of people not knowing what a doula is, and now it's a part of can they actually afford a doula. So now that comes with scholarships and fundraisers, things of that nature, where it comes with you having to raise up money to have other people have a doula. I know on my part with my business right now, we do a lot of like community events. And so people who do know what doula is and have a value with the doula, they'll try to incorporate so people who don't know or may necessarily need one can afford it. That's a major situation. And hopefully, insurance, eventually we'll be able to pay for it.
Thank you. So I'm going to ask the next question. What are some lessons that you have learned and hope others can make note of regarding doula work and the perinatal process in Western Massachusetts and beyond?
Oh, that's a good question. I would say definitely one thing that I have learned throughout the perinatal, meaning with the moms, correct? Or the perinatal period, right, with the moms. I would really, one of the major things is they really want somebody who they can confide in when it comes to mothers. Having somebody, oh, thank you for putting the question there. Having somebody who they can talk to is a major situation, or I think really does get to a mom's heart. Meaning like they might have their mom, they might have their sister, siblings, but to have somebody who you necessarily knows is on your call and can answer your questions when it comes to your emotional support, or you can just be stressing. A lot of times you tell somebody who's older, like your mom or your sibling, sometimes they're not there to comfort you to that level where you need to be comforted. Or maybe they feel like intimidated because they've already been through this. They might not know exactly what I'm feeling. So we're that person who can actually just go to them, or they can come to us, and we're there to ask a silly question like, why is my right arm hurting and I'm stressing, just something out of the blue, but you necessarily can't call your midwife, and you think maybe it's in your mind, so you don't really want to talk to your mom. And that's what we are. We're doulas. We're somebody who's there to just make sure that you are just okay and stress-free.
Yeah. Yeah, I think a lot of people, one of the big things I push with my clients is education, is childbirth education. I teach, obviously, like I've taught more after this last year in COVID. But I really want people to have a good idea of what they're getting themselves into, what kind of system you're signing yourself up for. Do you know your OB office that well? Have you seen every person there? That's like, try to get a good read for how they feel about your birth plan. What kind of advocacy things do they know or feel comfortable with? It really is about coming from a place of knowledge, right? And I feel like part of my job is to help people understand really just like what this journey is all about and what you're walking into, specifically when you go into a hospital versus like a home birth or a birth center situation.
That was a great answer.
Yeah, thank you so much for that. And this is a little off script, not like a pre-planned question, but I just noticed this, as I was introducing you and also just hearing some of your work. I noticed that both of you started sort of around the COVID-19 pandemic. So I was wondering,
what about the current pandemic kind of highlighted these disparities for you, and what types of problems were you seeing that kind of moved you to action to work as a doula, and Dashanna, for you to found Caring for Mamas?
Yeah, so I started doula work prior to COVID. I started doula work because I had a really long, and what I call now as a doula, a standard induction, that I had no idea what it was. I didn't know what I was signing up for. I was way past due and just ready. And so, yeah, that happens to a lot of people. And so after that process, I was like, people need to know. There's a lot that they're not going to tell you. And I found out that doulas do that kind of work. They help kind of hold your hand. During the pandemic, all kinds of crazy stuff has happened, y'all. Like the kind of stuff that OBs get away with, the kind of stuff that hospitals, the kind of policies that they're putting in place, denying people support. Those aren't laws or anything like that. That's hospital policy, it's bureaucracy. And I feel like, again, especially in COVID, my job is to help people advocate for themselves and educate themselves so that they know they don't lose their agency when they walk into the doors of the hospital.
Yes. So yeah, it's pretty much the same thing. Crazy, because same thing. My son is 11 now, and I believe that pregnancy was very, very traumatic. I was induced, but you know, they're just throwing stuff at me, and I'm like, you know, they're doctors, whatever you say goes. So
yep. You're wearing the coat, you got the degree. Yep.
Oh yeah. But then, you know, now that I think, I'm so sorry, y'all. Now that I think about it now, or now that I know better now, everything could have been prevented. Everything I didn't need to do, I had my option. They didn't give me my options. They just say, you have to do this, you have to do this, you have to do this. But I had options. And after my son was born, mind you, I had ended up having a C-section, and I had a C-section because everything, like the monitoring fell off. But they ran in saying that he didn't have no heartbeat. But I'm trying to tell you that it fell off, but you're not listening. So those right there, things like that are like common things that happen because you're not listening to the person who is telling you what's going on. I understand that you understand that you're watching him, but if this all of a sudden the heartbeat is not there, and I'm telling you, so anyway, I can go on with that.
We've all been, I was there. I've been there. Yeah.
But like as time goes on, I realized that this is not something that I want other people to experience. This is not something that I want I want a woman's voice to be heard. Oh, I didn't have no support there. My mother, she's not the type who likes to be in that facility. She doesn't like to be, you know, she don't like to see her child worked up. So she wasn't in the hospital. My grandmother was going through dementia and bipolar at that time. I didn't have no aunts. I don't have no siblings. So it was just me and my partner. We were the only ones there, and he didn't know. He don't know what to go on, you know. So it was just me. So obviously we're listening to everybody. I had no person there. I had no person to advocate for me. I had no person who can tell me my other options. I had no person. Okay, I'm in labor. I'm in labor, and somebody's not telling me, okay, you can do this. It's just another thing. It's just a surge. It's gonna come up. It's gonna go down. I didn't understand that the Pitocin, it makes it 500 times worse than what exactly I could have been through. I didn't know that I didn't have to take the Pitocin. You know, there's so many different things that happen. I didn't, let me see, I had to sit still through a contraction. And the one most thing that just happened for me is I had a nurse that came in there and I asked her, am I going to be able to, is it going to get any worse than this? I remember this vividly, y'all. I remember this. I said, is this going to get any worse than this? I said, I can do this, right? I told her that I can do, because my girl was doing natural. I can do this, but is it going to get any worse? Because, you know, I don't know. And she came to me and said, if you can't handle this, you ain't gonna be able to handle how it's gonna be. You might as well just get the epidural. So obviously I'm gonna, no, even after that, I still was like, I don't want to listen to that. I'm gonna try something else, because the Cetaphil, something they gave me, something else that was more. No, but it was something that they gave. Yeah, it was a pill. They gave me a pill. And then I came back and the pill was working, and she was like, don't you want to get some rest? She came, same nurse. Don't you want to get some rest? This is only going to give you 2 hours. The epidural will give you a rest all night long. So she's pushing for what I don't want. This is my first
Yep.
child and she's pushing for what I don't want. So I needed somebody to tell me, okay, you got this. You take that little bit of rest so your body can, just rest a little bit so you can just pump this all out. I needed somebody in my ear like that. I wanted to be, I knew what I needed. So I became that person who I needed. Next go around with this baby, I have a 2-year-old right now, and I did a VBAC. I had my doula. I was at home. I labored the whole time. I knew education is the major thing. I knew exactly what was going on with my body. I had somebody there to do counter pressures. I had somebody there to keep my mind to what my end goal was. I had somebody to rush me to the hospital just in case. But long story short, I made it to that hospital and I was 9.5 centimeters dilated. There's no more
Yes.
interventions. There's nothing that y'all can tell me to convince me I didn't do anything right. I did this because I knew what my body was going through and I was able to do what I needed to do as a woman. And so I want to make sure that every woman has that option and that opinion to do whatever they want to do and how they want to do it. Whether it's you want to get epidural, that's fine. But you're not going to have nobody here telling you that you can't do it and it's not your choice. So that's my story.
I love it. Yeah.
All
of us have a story like that.
I didn't even
Every
get
single one. Yeah. It's either our labor.
Did not start. So I've been a doula. So I really got into doula work. I'm just gonna say like 2017. But the pandemic really I had to buckle down and really buckle down because of what was going on in the hospital, what was going on around me in the medical fields. People weren't getting that. First of all, the education, they weren't being seen. They didn't have the support. They wouldn't even let their parents in, and the parents in or spouses in. They wouldn't let nobody in. So that I started to be more of the virtual. I started being more protected and going to people's houses more, which is I know is a bad thing, but at the same time, they really needed it. And there started to be a lot more home births that I was actually accustomed to. And then in Florence, Massachusetts, at the birth center, that became really popular also. So I ended up doing a lot of births there and a lot of home births while the pandemic was going on. I went on to a tangent. I'm sorry.
Thank you so much for sharing all of that, your valuable experiences, and also kind of the importance of education and providing people with knowledge about these options in advance so that they know what to expect. And kind of just connecting your doula work to Western Mass. We've already highlighted some disparities that exist, both that Marwa and Sabecha highlighted in their research, but also that, firsthand experiences show in terms of accessing these centers and accessing care, especially in Western Mass. But I did want to ask, what have been some advantages or successes in your doula work in Western Mass? And what keeps you coming back to continue this work?
I guess I'll start. I don't live in Western Mass. I live in Lowell. And so like Tanita's website says, especially Black doulas, we travel like pretty much wherever our clients really need us, because there aren't like a million of us just like hanging out and around. They are becoming much more, which is wonderful. And people are knowing more about doulas and things like that. But I love going to home births. Man, like that's been one of the best things to kind of come out of the pandemic, especially in Western Mass. Like I've attended home births in Chicopee and Holyoke and Springfield, and it's been one of the highlights, honestly, of my like doula career for sure.
I would say I became quite well known at these hospitals up here. not that it's like a bad thing, but they know that I am very much of an advocate for my clients. Not necessarily in a bad way, but you are going to know that Tanita is going to voice her opinion. And if not voice her opinion, then her client is going to actually voice their opinion. They're going to know that Tanita is well prepared. And so, but the thing that I love, but they also know that I have their back. So meaning like the OBGYNs know that this is not going to be somebody who's going to continuously come and ask for them. The midwives know that, okay, Tanita's here. Okay, she's okay. Like they know that. I've been with them now for the short period of time. Sorry, my son was waking up. This short period of time, they know that I have the reputation now that they know that the client is going to be relaxed and comfortable with me being there in the room with them. And that's a good thing too, because prior to me and Springfield Family Doulas, which is me and my cousin LaCunia, there were other doulas that actually gave doulas a bad name in the city of Springfield. So when I first got into the hospital, was visiting and know of a doula, they were kind of skeptical because, but now they're like, okay, Tanita's here, okay, cool.
Thank you so much. So for our next question, we were wondering, what do you envision for the future of birthing resources and experiences in Western Massachusetts, especially in terms of doula work?
What is the end goal, did you say?
Yeah, so what do you envision for the future of
myself? How I envision it in Western Mass, I envision it like, okay, you go to your doctor's office, you go to your OBGYNs, you go to your midwife. The first or second appointment is, here's your list of doulas in this area. This is the doulas that you can pick from. We have on let's say November 17th, we have a day when we have all the doulas in the areas, and it's like meet your doulas, and then you can pick your doula, and it's actually, covered by your insurance. That way, like, no woman will be without a doula, and they will actually be taught by their midwife or told by their midwife or their OB what a doula is and why they feel like it's necessary. Like, that's how I envision it. I envision it like it's just automatic. Like, just like, when you're pregnant, you automatically go to the doctor to go check on your baby. You automatically feel like a doula is necessary.
Yeah, that would be amazing. That would honestly be amazing to have OBs and midwives both on board with doula care and doula work at Bay State, especially places like that where you really need to advocate for yourself. You really need to advocate for yourself. And I'm sure that you've seen it, that some places are more old school than others. And if they could all, like, one, if insurance paid for doulas, it would be like, okay, well, we can't really deny the reality and the evidence that says they are good for pregnant people, period. Right? Until insurance does that, OBs can go, I don't really know. Don't you got to pay for that out of pocket? I don't really know. And your client gets, I'm not really sure if I want to pay for this, or I'm not really sure about the investment. And believe you me, I've had more than one client that I've talked to in birth who does not hire a doula. And in postpartum, they're like, yeah, I kind of wish I hired a doula. Like, I kind of wish I had somebody there so I'd known a little bit more. I wish that, yeah, right. I wish the future of doula looked a little more like educating people outside of the hospitals, because the hospital education includes a lot of bureaucracy. It includes a lot of policy, like I said, and that's just not law. And you tend to lose your agency going into the mind frame that, like, oh, I have to do X because nurse Y at the CBE class said that this is just what they do. And what they do may not be best for you, right? So starting there would be amazing, but the insurance piece is fantastic as long as, we're paid what we're worth too. And like, it's honestly listed as a valuable service, just like lactation consultants or anything like that for pregnant people.
Absolutely. Thank you so much for that. I especially really find the part where you said education outside of the hospital to be super impactful, because I feel like when it comes to a lot of maternal health disparities, it's always emergency intervention or towards the end,
Yes.
and not really a lot of
Yes.
preventative work
Yes.
in all
Yes.
spheres of life. So I think that's huge.
Yes. Yeah, and birth is a natural event. So like the fact that it's like emergent, urgent all the time. And the worst things people think about are in these really urgent situations. And Tanita can tell you that's just not the reality of birth, really 9 times out of 10, you know? So sorry.
No, that's perfect. Thank you. And then for our next question, I was wondering, in your perspectives, how can health equity and diversity be increased in Western Mass, but also across the state and country in terms of the doula workforce and representation across the healthcare sector? And I'll put that in the chat. It was hefty.
Okay, yeah, I'm looking for that one in the chat. All right.
You want me to go first?
Me
I'll go first. So to start with, like in the workforce, right? Like doulas are not, there's no streamlined process for doulas like there is for doctors and things like that. No streamlined certification process, all that kind of stuff. So first of all, like there just need to be more doulas, period, wherever they come from, like whatever source they come from, there just need to be more of them, like more trained doulas. I am certified. I don't care if people get certified or not, but you do need to get some kind of like baseline knowledge. Not everybody can be a doula. And then to another point, we need more Black healthcare workers, period. That's really hard because that has to start basically in elementary school, letting kids know that they can't continue with math and science beyond 3rd grade or 4th grade just because they're Black or a woman or anything like that, right? So one, we would love to see more Black people like represented in our hospitals, in our healthcare workers and facilities, and then having really doulas be recognized as just as important as other healthcare workers, as part of your birth team. I tell people all the time, I'm on your team. I'm on your birth team. I want your doctor to know about me. I want your nurses to know I'm coming. I want everybody to know I'm coming because I'm on your team, right? And I want that kind of same respect that I'm gonna show them when I walk into the room. I don't want them thinking, you got a doula, right? No, this person like has been with me and walked with me throughout this pregnancy, just like you have. In fact, I've talked to them more than you. So they deserve just as much importance as everybody else on the team.
When she said that there needs to be more Black health, people in the health field, just to give you like, there's Bay State and Mercy that are 2 hospitals here that do labor and delivery. Mercy, there's 1 midwife that's Black. Bay State has none. Bay State has 1 OBGYN male who has been there forever. And he's like, don't want to change the way that he
doesn't believe in intermittent monitoring, doesn't believe in mobile monitoring. You got to be hooked up to the machines 24/7. Yeah, that old.
He checks you every week from the time of 35 weeks until, which he has no business doing that.
Right.
He doesn't want
cervical exams.
Like it's crazy. It's crazy how, and the whole time that I've been there, I've been doing births back to back as of late, because pandemic babies, And I've seen 1 Black nurse at Bay State. So that just tells you right there.
That's because you've been there back to back. I've never seen him.
Oh, wow.
Yeah.
That's because I've been there back to back. So, that just tells you right there. And then imagine being somebody who already doesn't trust people or trust anybody that's not of their ethnicity. And there's a how do you call it? There's a shield that comes down when you're with somebody that you're familiar with or feel like you can be familiar with. And when that's there, now you're tense because of that, and you're tense because of pregnancy. And that's just something that we need to do better with all around. All around.
Yeah, our people need more comprehensive care.
Yeah.
Yeah.
Thank you so much. I completely agree that we definitely need more Black health workers, doulas, and
I'm sorry, I'm gonna have to, so there's a comment about the Bay States, and I'm actually part of that grants, and I'll actually have a meeting.
Fantastic! Congratulations!
Thank you. They've actually hired us from Family Doulas to be the doulas,
Yes,
the doulas and everything else. So I'm excited about that.
That's fantastic.
Thank you. Thank you.
thank you so much and congratulations.
Thank you.
And for our final question for tonight, we were wondering, what can we as students, providers, researchers, advocates, and more do to support your work and to work towards greater access and awareness about doula care?
How I tell everybody is have an elevator speech ready. Some people say have an elevator speech ready when you never know what you're gonna meet with your business or whatever. So have it just an elevator speech ready when it comes to a doula. Hey, do you know what a doula is? We see somebody's pregnant, or somebody in your family is pregnant. Give them the insight of what a doula is, how they can help them, how we're different than midwives and OBs, what exactly are statistics. Like, just have a little elevator speech for them real quick, so that they'll just know. At least it's in the back of their head that I was the type of person prior to me being a doula. Somebody tell me something, I'm a big hypocrite. So you don't know what you're talking about, but I got the little thing in my head, but you don't know what you're talking about, and I'm gonna go do my own research. I'm just a whole, I like to do my own study. I like to know my own when I'm behind it. So if somebody says something to me about what a doula is, and I'm over here stressed out, tired from walking, 8 months pregnant, you don't know what you're talking about. I'm gonna Google it on my phone and know what you're talking about, because I don't understand what you're saying. So at least they get that little seed, a drop in the seed, and they're able to do just look for themselves, and then they can spike up an interest. And even if they don't have it, they can probably tell somebody else, and they might have an interest. But some way and somehow, everybody will know about what a doula is, because that's all it is. We need more awareness of people knowing what a doula is.
Yeah, we do. I think anytime somebody is pregnant, offer to help them pay for a doula. Offer to help them pay for it, right? Don't buy them a high chair. Don't get them a stroller. That stuff is gonna get covered. Always. Somebody's always gonna buy the cute crib, the cute clothes. Can I help you, pay for support in any way? And that doesn't actually have to be a doula, but mention doulas. Can I get your house cleaned? Can we get you meal prep doulas? What can we do to support you? Not buy you junk, right? And then that really gets people's wheels turning about, well, what kind of support might I need in birth? What kind of support might I need postpartum? Meals sound really great. You know what I mean? Doulas do that kind of work, right? And I tell people I don't do hard labor, but I'll help you clean your house. Really, we do that kind of stuff. We help baby, we just hold the baby, or we do all the other things so you can hold the baby when you really want to. Just introduce the idea, right, of other ways to support people while they're pregnant or in postpartum. And it goes from there. It really does.
Thank you so much for that. We have a few minutes left that we could take extra questions, but before we do that, I was wondering if we could turn our cameras on for a group picture together, just to remember this event and our time together. So feel free to turn your cameras on if possible. It would be great. I'll give everyone a few seconds and then I'll take it.
You turn it right on.
It's okay. You don't have to be dressed up.
Hey, Brianna, it's Toya. Hey, Brianna and friend, y'all cute.
Okay, perfect. Everyone, I'm gonna take it. So say cheese.
Hey, give us a 3 countdown. So
Okay. I thought cheese is enough.
We need 3, honey. We need 3.
Okay. 3, 2, 1. Perfect. Super cute.
Yay.
Amazing. Thank you so much. We have
Yeah.
3 minutes left. I know there was one question, I believe Marwa asked it earlier on, and it was, how are your experiences with providers when it comes to advocating for patients?
Well, with me personally, I've had some good experiences and I've had some okay experiences, meaning like midwives, I love the midwives. Like I haven't, well, I don't like midwives, but she's not here anymore, so we're not gonna talk about that. But the OBs, I would think that midwives are more like they know the new research. They're always trying to do the new stuff. They always trying to be no hands-on. They know what the benefit of doula is. I feel like a lot of the OBs feel like we're trying to what's the word I'm looking for? Like come on their property or like you like you get what I'm saying? Like we're trying to like say what they're doing is wrong, or they're more like
overstep
that.
our bounds.
Thank you.
Yeah. And that's not
right
yeah.
That's what they feel like. Yes, they're definitely nervous. And I've noticed that they are more like, okay, I'll give an example. I had a client, she was pushing her baby out. Well, the baby was declining, heart rate was declining every time she was pushing. A little bit was declining slightly. She was pushing the baby was almost out, and out of nowhere, the OB took some scissors out, was about to do an episiotomy. We're not doing that. Okay, so excuse me, ma'am. Excuse me. Hold on, real quick. Can we talk to my client real quick about before that happens? Because first of all, you didn't even give no consent. You didn't tell the client that you was about to do that. So now you're about to mutilate her body without her even knowing. That's not going to happen. So did she get upset at me? She did. But at the same time, you're not going to do that. You're not going to do that. Yeah. So, I mean, at least give her not even a heads up. Ask for her permission. Like, we're not doing that. So, I mean, like little things like that, they'll get annoyed. You can get annoyed with me all day long with that because you're not gonna you're just not gonna do that. Right. This is what they
I'm still
hide.
Gonna do my job.
Like that won't happen. And this is how we have an increase in our morbidity, because you're just doing things to us without even giving us permission or without even letting us know what's going on with our body. And that's not okay. So I hope that answered the question. I feel like I just went off of it.
No, it is. The relationships aren't bad necessarily. Like I have really decent relationships at all the hospitals. Honestly, because I'm a part of the team. So we're talking, I'm part of the conversation as soon as I'm on board. I'm like, did you tell your OB I'm gonna be there? Because I'm gonna be there. They're gonna see my face, And so when I get there, everyone's looking like, maybe they aren't looking forward to seeing me, but they act like they are. And and then we pull out the birth plans that I create with my clients and we go through it. We make sure that things are still looking on board and, nobody's doing anything or offering anything they don't want to be offered. It's like I said, you're part of the team. So that needs to be a team atmosphere from the very beginning. If your OB or something is not comfortable with me being there, they're the only one who's going to be uncomfortable. Right. Like I'm going to let they are the only person in the room who's going to be uncomfortable with me being there because I'm going to be me. So there's and most people get on board with that because my client's on board with me being there. And your patient comes first, right? Patient-centered care, especially when it comes to pregnant people, should be first and foremost. And OBs really, we put that to the test in their face sometimes when the doulas come in the room, but they mostly save face and act right.
So with myself, I know I personally go see my client. Prior to COVID, I would always go to like 1 or 2 appointments with her at her OB or but during COVID, we did a video conference so that the doctors or the midwife know that I am there or will be there, so that they are familiar with my face and they just are familiar. And I did not make sure that they do let them know, like during one of those appointments, that they do have a doula and then I will be part of the team and then I will be there. And during the time of like when they're in labor, I don't have the client call the doctor to let them know that they're in labor. I mean, they'll call me first, and then I'll head over, and then I'll call the client. I mean, I'll call the doctor or the midwife and let them know, how far along she is and how long the contractions is, so that they are familiar that I'm the one who is calling, and I am the one who they're going to be calling back to, so that we have a little bit of connection. Whether it's the answer service or whatever, when the midwives or whatever call back, I can call my number back so that she ain't got to concentrate on that. Or maybe the husband might do it or the partner might do it. But at the same time, it's going to be me, so they know that I am there at the same time. Somebody asked another question about, I'm sorry to cut you off. Do you want to do it, Sawar, or you want me to just look at the question next? Okay. What is like building a relationship with expecting postpartum mothers? Is it difficult to build that trust and maintain? And how are conflicts resolved? With me, myself, I don't feel like it's that difficult building a relationship because I'm going to be me all day. I don't know if y'all realize that right now too. Like, I'm me. I'm going to talk. I'm going to be real. I'm going to let you know what's going on. I'm going to let you know, there's going to be a comfortability. If it's not a comfortability, I have never had a time when there's not a comfortability. And I feel like the relationship has to be built, whether it's because with my practice, it's either me or my cousin. So it's one or the other. She's a holistic doula, and I'm a full spectrum doula. So it's like you get to pick whichever one you want to do to be your main doula. But if we are your back, the other one will be the backup. So we want to make sure that you are, because when you are birthing, that's your most intimate time. Like, you are going to be wide open. So we need to be a little bit comfortable, man. Because there's no secrets after this,
Yeah, right.
So you just got to be as comfortable as you can. I've never had a conflict, but obviously if there would be a conflict with the person that I am right now, there would just have to be a time when you and I just have to come together personally and just talk about it, because I'm not a person who's going to sweep anything under the rug. And if there's a problem, we're going to talk about it, we're going to resolve it. That's
I like, relationships start from when the contract's signed, as far as I'm concerned. So if I don't hear from my clients, they will hear from me. Like, at least every 2 to 3 weeks, you're having appointments anyway. Like, I want to be notified. I do tell all my, I give all my clients like a when to call me sheet. Like, I want you to know that, like, I want to hear from you. And if you don't tell me about your appointments, I'm going to start asking about them. Right. It really isn't difficult to maintain. I mean, like, it can be hard to maintain extra relationships, to be honest, because suddenly you're texting about like all these new pregnant people. And that, like, your friends, you don't text them back ever. You text back your clients who are like, I don't want to go to Google. What's this? What's going on with this? And as far as conflicts, it's a relationship. So anytime there aren't a lot of, also it's a client relationship. So there is a payment process involved in this too, right? So if people were upset about something, or it would mostly be something contractual, not necessarily relationship wise, because as long as you know what my role is and I stay within the bounds of that, we're really good. I think I can't even really think of conflicts. Every once in a while, partners aren't exactly 100% sure what they're gonna do if a doula is there. And that fear goes away once the birth is happening, because they're like, oh, I am very much so involved. And so is this doula person. But in the beginning, they can feel a little left out. And it's really the doula's job to make sure that they know this is your baby. Like, I get to go home after this, so you really jump in there and stay in there. And then another question I see is, how can we support doulas in their integration and insurance coverage plans? So there are multiple bills being proposed at like various times in Massachusetts. Throw your support behind them, right? Like, some are just for Medicaid to cover doulas up to a certain amount. And that's fine, but talk to people about it, like, ask questions, vote for it if it ever gets to that point, right? But honestly, what you're doing right now is pretty supportive, to be honest.
Yeah.
Having these kinds of conversations, letting the community know. I mean, I saw a lot of people were saying they're freshmen, and that's if I had known doulas existed as a freshman in college, I'd have a whole different career going right now. Like, I mean, this would probably still be my career, but it'd be in a different place, right? But I'm so excited that all these people are interested in doula work and like want to learn more about maternal health disparities. We all came from this, right? We all entered the world through birth. And so I think it's weird that people aren't interested in it. And I love that you guys are.
Thank you so much for that. We are at time, so I just wanted to say thank you so much for being here today and for guiding us through such an interesting conversation. And just because we've reached the end of this event doesn't mean the conversations end here. And I think that was the ending point that you just brought up, that the conversation should start early and continue throughout one's lifetime. Yes. So thank you so much for all of these great points, and hopefully we can see each other in future events and continue this dialogue. But yeah, thank you so much, everyone, and have a great night.
Thank you guys so much. This was great. Have a great evening.